presentation is about oligometastatic colorectal cancer. And this is the content of my presentation. Some introduction about the concept and definitions of oligometastatic status, and stereotactic body radiotherapy in colorectal cancer in general, and more specifically in liver and lung metastasis. Possibility to combine stereotactic radiotherapy with immunotherapy, and some concept about feasibility. Well, oligometastasis, probably you know this recent paper. If not, I suggest you to read it, because the actual scenario is a little bit more complicated. We call oligometastasis the one appearing synchronously with the primary tumor. When they are metachronous, okay, the primary tumor has been cured, but later we see metastasis, we call them oligorecurrence. Or when they appear after an active systemic therapy, we call them oligoprogression. And when there are metastases, several metastases, and after systemic therapy, we have only few metastases, we call them oligopersistence. So there are now several definitions of the oligometastatic status. General concept about colorectal cancer treated with stereotactic radiotherapy. Consider that 1/3 of patients diagnosed with colorectal cancer has oligometastasis at presentation. And considering the huge number of these tumors, we are talking about a very large population. The term oligometastasis was first used in 1995, but actually metastases, especially in the liver, were treated with surgery since the 40s, meaning in the colorectal cancer, we treated oligometastasis before oligometastasis were defined, and the results were not bad. So there was a proof that treatment directed to metastasis can be useful. Some general concept about which parameters are predictive of response and outcome. One is site. You can see that nodal metastases have better local control compared to visceral metastases. And they have also have a prolonged median progression-free survival compared to visceral mets. Generally speaking, the studies show that nodal site, good performance status, and wild-type KRAS were correlated with a better prognosis. You can easily see here how the progression-free survival of nodal metastasis was better compared to the other sites, and the same was for overall survival. In this study, again, they try to find some predictive factor of outcomes in stereotactic radiotherapy of colorectal cancer. You see median survival is around 3 years, 5-year overall survival 25%, local failure 30%, not the best probably. Negative prognostic factor was advanced age, larger metastasis, and again, KRAS mutation. You can see here overall survival, and you can see here the curves of wild-type KRAS patients and patients with mutation. And you can see a huge difference here between patients with mutation of KRAS and P53 and non-mutated patients. So probably in the future, we will stratify patients for stereotactic also based on genetic factors. Another study showing again relatively good results in terms of survival. 5-year local control 77%, and improved overall survival when the dose is important. The dose is able to impact on overall survival. This is a very important concept. In particular, you can see that biologically equivalent dose with an alpha-beta ratio of 10 higher than 100 is needed to improve survival. And improve survival also in male gender, again in younger patients, and obviously in patients with a single metastasis. You can see here the clear impact of the dose on overall survival and the huge impact of the dose on local recurrence rates. This study is interesting because we present the results. Again, local progression not the best. Very good overall survival, better overall survival in primary tumor was cured, smaller metastasis in patient treated with fewer lines of systemic treatment, lower tumor marker, but they analyzed the possibility to postpone systemic therapy. Okay, a patient has some metastasis. I treat with stereotactic radiotherapy this metastasis, and I try to postpone the start of systemic therapy, of the change of systemic therapy. And actually, SBRT was effective because after 2 years, 42% of patients were free from systemic therapy or change of systemic therapy. You can see again here the huge impact of the dose on local control and also on the side. These are liver metastases. They have more local progression. These are lung colorectal metastases, and the local control is better and better. So let's talk about liver metastases. They are common, as you well know, in colorectal cancer. We can treat them with metastasectomy, but some patients are not candidates for surgery, and so SBRT has been tested in this particular setting. There is a systematic review showing 2-year survival of 56%, median survival of 31 months, local control a little bit disappointing, but again, a clear relationship with dose and local control, and more importantly, on overall survival. Toxicity, severe toxicity was rare. You will see that this is common using stereotactic radiotherapy. These are the forest plot of this systematic analysis. This is a study about all liver metastases coming from every primary tumor. They had better local control, 15% overall survival, no severe toxicity at all. And they noted that the worst local control was recorded in patients with colorectal cancer. So colorectal cancer with metastasis in the liver probably need to be integrated with systemic therapy or should be delivered with the highest possible dose. You see here in these two curves how local control is worse in patients with colorectal cancer. Another paper about prognosis, overall survival, 44% of the year. Again, local control not the best. The extrahepatic disease, metastasis also outside the liver, obviously have a negative impact on progression-free survival and overall survival. But again, you can see that severe toxicity, the rate is 0. And this is the curve of local control, not particularly exciting. However, these voters compared stereotactic radiotherapy with microwave ablation of colorectal liver metastasis, and they saw that local control was significantly better with stereotactic radiotherapy compared to microwave ablation. You see here the curves. This is stereotactic radiotherapy, this is microwave ablation. Lung metastases, they are frequent. They can be resected, but after resection, we have a 70% of recurrence, most frequently in the lung. And in lung, it's not simple to perform repeated surgery because obviously surgery impairs lung function. So also in this setting, stereotactic has been tested and used. Also in this case, there is a systematic review showing that the 5-year local control is better than in liver metastasis, and overall survival can be very good. These are trends of survival and local control during time. Interestingly, studies evaluating toxicity in this setting showed in most cases 0 rate of severe toxicity. So it's a tolerable treatment. Again, what impacts on outcome? Both local control and overall survival are influenced by previous local therapies that are worsening both local control and overall survival, and by higher dose. Again, the dose is important in this setting. The authors concluded overall survival was good, but as always with colorectal cancer, local control is not the best. You can see here the curve of local control. This study support the same concept. You see lung metastasis, median survival, 3-year survival, not bad. Progression survival at 3 years is 15%, but 36% of local recurrence. Again, no toxicity, no severe toxicity, but the authors concluded, as always, that local control is lower compared to other primaries. We need probably higher doses in these patients. And this is the curve of local control in these patients. This is an interesting experience because what the authors did, they treated patients with oligometastasis. Then they evaluated them. If they recur with oligorecurrences, so few metastases, they treated them again with stereotactic radiotherapy and again until the number of new metastases was less than 5. They stopped using stereotactic radiotherapy when they develop polymetastatic disease. And they saw that in this way, the time to reach the polymetastatic status was more than 2 years. And this is an interesting strategy. It's used also, for example, in prostate cancer. There are patients with prostate cancer developing several oligorecurrence, and they are treated and treated and treated until the metastases become more than 4 or 5, something like this. You see the difference in terms of overall survival in patients treated with repeated stereotactic radiotherapy compared to the one developing from the beginning a polymetastatic status. When should we evaluate response? We were talking before about response after chemoradiation, and we say that the rate of pathological complete response is higher if we wait for a longer time, possibly more than 13 weeks. And it's the same for oligometastasis. In this series, they evaluate the rate of complete response, and this rate was, after 2 months, only 25%. But after 5 months, was 44%, And that last follow-up, it was close to 50%. So you cannot evaluate response too early. You have to wait an adequate time before saying if the response is complete or not. Again, they recorded better local control rate with higher dose and obviously in smaller metastases. Again, severe toxicity rate was 0. And you can see the impact of response in these patients. This is overall survival. Patient with complete response after stereotactic radiotherapy had 100% local control at 2 years. So it's important to reach a complete response and so to use an adequate dose. Can we combine stereotactic radiotherapy with immunotherapy? Someone thought that maybe being this tumor not particularly sensitive to immunotherapy, maybe we can convert them in responsive tumor by using radiation, because this happens in several settings. So radiation maybe could be in the future a fire starter rather than the fire to improve the immunomediated response. Is it true? We don't actually know. We have to wait the results of several studies ongoing on this issue. Then feasibility. I'm so sure that Professor Sumon will ask me, but you know, we are in Bangladesh. Can we use stereotactic radiotherapy? Because most of our departments are not supported by high technology. And my answer will be no, of course, because to perform stereotactic radiotherapy, you need image-guided radiotherapy, you need 4D CT scan, so 4D radiotherapy, you need surface-guided radiotherapy, possibly some robotic machine. Are we sure that we need all this technology? Okay, this is the way I treated patients with stereotactic radiotherapy since 2003 up to 2014. This was a very simple linear accelerator, no micromotive, no image guidance, just a particular immobilization system. And these were my results on 400 patients treated with stereotactic radiotherapy. You see, 2-year local control, 70%, 10-year local control was 60%. Probably not the best results in the world, but you have to consider that in 2003, 2004, 2005, I was using a relatively low dose of radiation because we were at the beginning and the experience on this technique was not so developed. But despite all these limitations, we had local control in most in more, of 50% of patients. But yes, this is a linear accelerator. What about cobalt units? Try to go on PubMed, write stereotactic radiotherapy and cobalt. You will see a lot of papers saying that, yes, we can adapt a telecobalt unit to perform stereotactic radiotherapy. And in particular, this old paper analyzed the dose distribution. If you are using very small field, multiple fields, possibly no coplanar fields, the dosimetric results are the same or close to the same of a 10 MV linear accelerator. And so they concluded that these differences are minimal and therefore of essentially no clinical significance. So you could talk with your physicist and maybe try. Because stereotactic radiotherapy, as I showed, is not toxic, is very effective, so it's very useful for our patients. So in conclusion one, we don't have only oligometastasis, we have oligoprogression, oligorecurrence, oligopersistence of disease. Colorectal cancer was one of the first settings where stereotactic radiotherapy was used because of experiences of surgery, especially in the liver. It's very well tolerated. Most serious report 0% of severe toxicity. Unfortunately, local control is lower compared to other tumors. And so the biological equivalent dose should be higher than 100 Gray. 5-year overall survival obviously depends by the setting, ranging from 15 to 45%. And stereotactic radiotherapy can be used to delay the start or the change of a systemic treatment. Conclusion 2 is my personal opinion. It does not necessarily require the use of all modern technological toys used in our radiotherapy departments. So this lady here, consider this lady as the company representative telling you, you need these, you need these, you need these. And these babies are radiation oncologists. These babies, all of them, they want more toys, they want the other toys. They are very, very jealous to have the last generation toys. But probably they are not needed to perform stereotactic radiotherapy. Finally, goodbye. Arrivederci is in Italian. I'm not able to read this line, but I hope you can read and understand it. And let's say I miss Dhaka, I miss your traffic, I miss my friends in Bangladesh, and I hope to have the opportunity to see them again. Thank you.